When we discuss first-line treatment, we're really talking about the initial preferred or standard therapy for a specific condition. These treatments are chosen based on, extensive clinical evidence, national guidelines, and a proven track record of both efficacy and safety. For you as a future family nurse practitioner, understanding these isn't just about passing your certification exam, it's about providing competent, evidence-based care from your very first patient encounter. These are your go-to interventions, the ones you'll reach for most often, because they offer the best balance of benefit, risk, and cost for the majority of patients. Think of them as the foundation for all your other therapeutic decisions. The selection of a first-line agent is a deliberate process, guided by organizations like the American Heart Association or the American Diabetes Association. These guidelines are meticulously developed by experts who review countless studies and clinical trials. They consider things like the medication's mechanism of action, its side effect profile, patient comorbidities, and long-term outcomes. For an FNP, choosing the correct first-line therapy really demonstrates your clinical judgment and your commitment to the standard of care. It's the most reliable starting point for managing a patient's health problem and achieving positive therapeutic results in a predictable and safe way. Mastering these treatments is, honestly, essential for exam success. Board certification exams, whether from the AANP or ANCC, are designed to test your readiness for practice. They'll present you with clinical scenarios and expect you to identify the most appropriate initial step in management. Questions will frequently focus on common primary care presentations, like a newly diagnosed hypertensive patient or a child with a sore throat. Knowing the first-line drug class and even specific agents for these conditions is a high-yield area of study. This knowledge forms a significant portion of the pharmacology and clinical management domains tested on the exam, so it's a critical area to focus your preparation efforts. But beyond the exam, this knowledge is your daily bread in clinical practice. When a patient presents with classic symptoms of a urinary tract infection, your immediate recall of the appropriate first-line antibiotic ensures timely and effective relief. Similarly, initiating the correct antihypertensive agent can set a patient on a path to preventing devastating complications like stroke or heart attack. This core knowledge allows you to practice confidently and efficiently, building trust with your patients and colleagues. It's the practical application of your rigorous education, translating textbook learning into real-world patient care that truly makes a difference in people's lives. For essential hypertension, the first-line treatment choice really depends on the patient's comorbidities and race. The JNC8 guidelines, even though they're a bit older, still provide a useful framework that's often tested. For most non-African American patients, initial therapy can include one of four classes: thiazide-type diuretics, ACE inhibitors, angiotensin II receptor blockers, or calcium channel blockers. A simple way to remember this is with the mnemonic ABCD, ACI or ARB, beta blockers, CCB, diuretics. Though beta blockers are no longer primary first-line agents unless there's a compelling indication like heart failure, for African American patients, thiazide diuretics or calcium channel blockers are preferred due to better efficacy in this population. Now, when it comes to managing type 2 diabetes, metformin is the undisputed first-line agent for nearly all patients. Assuming there are no contraindications like severe renal impairment, metformin is chosen because it works mainly by decreasing hepatic glucose production, doesn't cause hypoglycemia when used alone, and can promote modest weight loss. It has a long history of safety and is incredibly cost-effective. Just remember, metformin is first man in for type 2 diabetes. If a patient's A1C stays elevated after 3 months of metformin and lifestyle changes, you then consider adding a second agent from a different class, like an SGLT2 inhibitor or a GLP-1 receptor agonist, especially if cardiovascular benefits are needed. Asthma management, on the other hand, follows a stepwise approach, with the goal of achieving control using the least amount of medication possible. For persistent asthma, the cornerstone of first-line treatment is a low-dose inhaled corticosteroid, such as fluticasone or budesonide. The ICS works by reducing airway inflammation, which is the underlying cause of asthma symptoms. For rescue, a short-acting beta agonist like albuterol is used as needed for acute symptoms. A helpful tip is to think controller and reliever. The ICS is the daily controller to prevent attacks, and the SABA is the fast-acting reliever for when symptoms break through. chronic obstructive pulmonary disease or COPD, management aims to reduce symptoms and prevent exacerbations. For initial maintenance therapy in most symptomatic patients, a long-acting bronchodilator is the first-line choice. This can be either a long-acting muscarinic antagonist, like tiotropium, or a long-acting beta agonist, like salmeterol. These medications work by relaxing the airway muscles, making breathing easier over a sustained period. Unlike asthma, inhaled corticosteroids are not a first-line monotherapy for COPD and are typically reserved for patients with frequent exacerbations. Remember, for COPD, bronchodilation is the primary goal of initial therapy. When a patient presents with an uncomplicated urinary tract infection, characterized by dysuria and frequency without fever or systemic symptoms, specific antibiotics are recommended first. Nitrofurantoin, or Macrobid, for 5 days is a top choice because it concentrates well in the bladder and has low rates of resistance against common uropathogens like E. coli. Another excellent first-line option is trimethoprim sulfamethoxazole, or Bactrim, for 3 days, but only if local resistance rates are known to be low, under 10 to 20%. A simple way to recall this is to think, for a simple UTI, keep it simple and local, meaning use a drug like nitrofurantoin that works primarily in the bladder. For a confirmed case of Group A streptococcal pharyngitis or strep throat, the goal of treatment is to prevent rheumatic fever, shorten the duration of symptoms, and reduce transmission. The clear first-line treatment is penicillin 5 or amoxicillin. Amoxicillin is often preferred, especially for children, because it has a more palatable taste and can be dosed once daily. The standard duration of therapy is 10 days. The reason penicillin family antibiotics are chosen is their proven effectiveness against Streptococcus pyogenes and their narrow spectrum of activity, which minimizes disruption to the patient's normal flora. Remember, penicillin is the perfect pick for pharyngitis. Managing an acute exacerbation of COPD requires a more aggressive, multi-pronged approach compared to routine maintenance. The first-line treatment consists of 3 key components. First, an increased dose and frequency of short-acting bronchodilators, typically a combination of a SABA, like albuterol, and a short-acting muscarinic antagonist, like ipratropium, often administered via a nebulizer. Second, a short course of systemic corticosteroids such as oral prednisone, 40 mg daily for 5 days, is crucial to reduce airway inflammation. Third, antibiotics are recommended if the patient has increased sputum purulence along with increased dyspnea or sputum volume. A helpful mnemonic for managing a COPD exacerbation is SAS-SABA or SAMA, antibiotics and systemic steroids. This triad addresses the immediate bronchospasm, the underlying inflammation, and the potential bacterial trigger of the flare-up. The choice of antibiotic, if needed, should cover common respiratory pathogens, with doxycycline or azithromycin often being appropriate initial choices for uncomplicated cases. This systematic approach ensures that all critical aspects of the exacerbation are addressed promptly, leading to faster recovery and reducing the risk of hospitalization. It's a vital protocol to have memorized for both your exam and your future clinical responsibilities. To succeed on your FNP certification exam, rote memorization alone just isn't enough. You really need to understand the why behind each first-line treatment. Create study aids that connect the condition, the recommended drug class, a specific drug example, and the rationale for its use. For instance, make a flashcard for hypertension that lists ACE inhibitor like lisinopril and notes blocks angiotensin conversion, preventing vasoconstriction, protective in diabetes and chronic kidney disease. This deeper level of understanding will help you answer application-based questions, where you have to select the best therapy for a patient with multiple health issues. This method transforms passive learning into active, critical thinking. Use mnemonics and create personal associations to help the information stick. For common dermatologic conditions, you might remember Canesten for candida, or associate the azole suffix with antifungals. For antibiotic classes, you could group them by mechanism of action or spectrum of coverage. Practice questions are your best friend in this process. Work through as many FNP exam-style questions as you can. Each time you encounter a question about first-line therapy, whether you get it right or wrong, take the time to review the correct answer and the explanations for all the options. This repetition will build your confidence and really solidify the connections in your mind. Form a study group with your peers to discuss clinical scenarios. Talking through a case study of a newly diagnosed diabetic patient allows you to verbalize the treatment plan, starting with metformin and lifestyle changes. Explaining the rationale to someone else is honestly one of the most effective ways to test your own comprehension. These discussions can also expose you to different ways of remembering information and help clarify any points of confusion. Group study simulates the collaborative environment of clinical practice and reinforces the standards of care you'll be expected to uphold throughout your professional career as a nurse practitioner. Ultimately, mastering first-line treatments is about more than an exam score. It's about patient safety and clinical excellence. These evidence-based guidelines are your roadmap to providing high-quality, effective care. By internalizing them now, you're building a strong foundation for a successful and impactful career as a family nurse practitioner. When you're in practice, this knowledge will become second nature, allowing you to make sound clinical decisions quickly and confidently. This preparation is an investment in your future and in the health and well-being of the countless patients you will serve.